Hey everybody, welcome to another edition of What's for Dinner. We're a little early today. We have a church function this afternoon, October 31st party, so I'll be working there. And originally we said we weren't going to do What's for Dinner tonight, but we had the opportunity to. So
Yeah.
here we are.
I got off early. I didn't even think I would see you.
Yeah, this actually worked out really well
Yeah.
today, so we're excited to be on here, and I hope you all are doing great. Just a reminder, if you guys have any kind of questions that are medical in nature, please reach out to your highly trained and knowledgeable healthcare provider, which if you're looking for somebody who specializes in hormones, there's a provider directory on worldlinkmedical.com. And if you're looking for anybody who specializes in metabolic health, low insulin, low carb, keto, carnivore, those sorts of things, there's a provider directory on lowcarbusa.org or smhp.org. All right, so
It's actually painful when you say that. Like, it's painful inside my body because you say highly trained and educated or highly trained and knowledgeable provider, but those same providers tell my patients that they can't go on hormones because it's caused breast cancer. You can't take progesterone because you don't have a uterus. Keto is going to kill you.
Yeah, kind of get that all the time, don't we?
Yeah.
And so do the patients, unfortunately.
Yes.
Right on. All right.
Okay,
well,
so
moving on. What do we got going on for dinner?
Yeah. We showed you yesterday in the crock pot, so I turned it on this morning about 7 o'clock, and this is what it looks like. I put cheese and sour cream on mine, which he does too usually.
We
But
didn't do tri-tips. What did we do?
They're just chuck roast.
Yeah, chuck roast. So we put those on about 9 o'clock this morning, or
7 o'clock before I left.
Okay, 7 o'clock, and it's not even 3 o'clock now, and it's all done and ready to go. So it
Yep.
worked out pretty good.
Yep.
So we got sour cream, cheese, Jane's Crazy mixed up seasoning, that kind of stuff. And I'll just show everybody. I kind of showed them at the beginning, but there's our crock pot. Basically just falls apart.
Yeah.
It's yum.
And I basted it with butter yesterday and garlic, fresh pressed. Oh, someone said it was called a head of garlic. That's what I was trying to think of. So I did a whole head of garlic in there.
All right. So that's our low insulin way of eating for today. And then so today's theme or topic is going to be Teresa wants to go over some case studies she has on 3 PCOS/insulin resistance patients that she has case studies for.
So PCOS is polycystic ovarian syndrome. And the typical features of that is, first of all, the root cause of that is insulin resistance. That's the problem, the genetic problem. So it's typically cysts on your ovaries, infertility or miscarriages, overweight, so weight gain, diabetes, gestational diabetes, hair loss on your head and hair growth on your face, and acne from the high testosterone. Now, I see the whole gamut. I see people that don't even present like that, people that have no problems getting pregnant, but
yet they have PCOS.
But they have PCOS. And I just had 3 people walk through my door this week. So the first 2 are young people. So one is 21 years old. She weighs 210 pounds and she's 5'7". She came in already knowing she had PCOS and endometriosis. But I'm just trying to give you guys what things look like and how you can see things coming before other people can. Her fasting glucose was 84. So not many people are even going to run a hemoglobin A1C on her because she's too young, 21 years old. But they will run a fasting glucose and hers looks completely normal. The hemoglobin A1C is the only way corporate medicine can diagnose diabetes. Once you get diagnosed with that, you've been sick for at least 15 years. You can see that coming for 15 years. So by the time they get you a diagnosis, it's very late in the game. And then her fasting insulin was not as bad as I thought it would be. It was 12. So the range for Quest is anything under 18.4 is normal. But in our space, we like 3 to 5 and below. So hers is 12, but she has trouble. She's going to not be impossible, but it's insulin resistance at the core. It's going to be a little harder for her to lose weight. Okay. Then the next patient was a daughter of one of my patients. She is 24 years old. Now, she's on the birth control pill, so I can't test her LH and FSH, which is luteinizing hormone and follicle stimulating hormone. When luteinizing hormone to FSH is 2 to 1, that's indicative of diagnosing PCOS. If it's higher, the ratio is higher than that, it's indicative of pathology, meaning they probably have symptoms. I did check this girl's FSH and LH just to see, because sometimes it'll pop through, but both of hers were suppressed, but that's normal on birth control pill. Her A1C was 4.7. Again, Her glucose was 84, like the girl before, but her A1C, if anyone decided to run it on a 24-year-old, was 4.7. That's amazing. No one's going to bat an eye at that. I don't have her height and weight, but she is a little bit overweight. But her fasting insulin is 16.3. So it's not abnormal according to labs. That's 18.4 and above flags as abnormal, but she's at 16. She's on her way and she's only 24. So that'll creep up and that'll be elevated and abnormal for a long time, 10 to 20 years before she pops abnormal on her hemoglobin A1C to get the diagnosis of diabetes. And then lastly is a 32-year-old female who is 5'5", weighs 225 pounds, and she has no idea of anything. But I take one look at her labs and I'm like, oh, you have PCOS. Did anyone tell you that? Her LH is 57.4 and her FSH is 17.3. So remember, 2-to-1 is diagnostic. Hers is more like 3-to-1. So that's pathogenic. That means you're seeing symptoms. So her A1C, first of all, her fasting glucose was 89. It's pretty good, right? It's probably what mine is. Her A1C is 5. So 5.7 to 6.4 is pre-diabetes. 6.5 and above is full blown. So she's at 5. I say I go over my labs, I write next to the lab result what I want it to be, and I write next to the A1C 5. I want 5 and below. However, her fasting insulin is 17.3. So at 18.4, you read high, and I want 3 to 5. So she's at 17. So she's on her way to diabetes diagnosis eventually.
You're catching it early.
Catching it early, yeah.
Yeah, absolutely. That's good.
Oh, and she had gestational diabetes because she's had children. So she's had gestational diabetes. And so this is all very normal things. And I think PCOS is very prevalent these days. And I think it's because we have so many endocrine disruptors messing with hormones and fertility.
Yeah. Yeah, it's unfortunate.
Which we'll do another study on or a video on. But my patient, the one who's my patient's daughter, was like, well, she has an appointment coming up with her GYN. How should she approach this with her? And I was like, she shouldn't. She's already on birth control. That's the standard of care for PCOS. And then she said, well, what should her PCP do for follow-up? And I was like, just change her diet, watch our channel. She'll fix it on her own. They're doing what they know to do, which is birth control pill, the end.
Yeah, it's unfortunate.
Very.
So what would happen? So all these girls you're talking about right now, under normal circumstances, if they didn't come see a provider who was running like a fasting glucose and whatnot, they would just keep getting shuffled along for the next decade or so. And then eventually probably, they're close to full blown diabetes, or at least pre-diabetes, before anybody does anything for them. Is what you're saying.
Well, when you go into your GYN as a female and you complain about cystic acne and hair growth and horrid periods, because that's another big thing with PCOS, they're going to give you the pill. All of those, whether or not they clump all of those under PCOS, they're going to give you the birth control for each individual one of those symptoms. So they're going to get birth control pill. What you guys don't probably notice, females, is when you go on any type of birth control, it makes you cuckoo. But you go back to the physician or the nurse practitioner and you're like, this is making me crazy. And they gaslight you like, that's not what birth control does. Birth control is completely safe.
Or they put you on something for it.
Right. Or you get it. Then they'd be glad to get some Lexapro or Effexor. But there are a lot of women, I think this generation right now, like my kids' age, I feel like are noticing a little bit more like, I don't feel good on this. Or, in my day, you just took it and whatever you were dealt from it, side effects, you dealt with that too. You did. You didn't say anything.
Yeah.
So.
Well, all right. Well, is that good for you for today?
I think so. It's just that the only way to treat this is low carb. And if you look at Low Carb MD podcast, Low Carb MD, look up Low Carb MD and Nadia Patagonia, which I think is episode 41, I think is 41. She does a whole episode on PCOS. Her and Jason Fung wrote a book called PCOS, but the answer is low carb. And those PCOS people need 20 to 30 grams or less a day
of carbohydrates.
They have to be pretty low carb.
Yeah. Okay.
Like gotcha. True definition.
Right on.
So, but you can reverse that, not have any issues. If you have PCOS, you need to be on progesterone during pregnancy. So what I tell these girls is when you get pregnant, the doctors have to put you on progesterone. Many won't. So I give them people like me to come to get that. And then the other thing is if you do get progesterone during pregnancy, they will stop it after the first trimester, because in our textbooks under theory, your placenta takes over after the first trimester and produces progesterone. But we all know women who have miscarried and had stillbirths at 4, 5, 6 months. So why would you bother risking it? So I tell these women, you have to be on it the whole time, find someone that will, and then you just go off at week 37. We check levels every month to make sure. Every week of gestation, you should have a certain level of progesterone to sustain pregnancy. But then at 37 weeks, you stop it and you deliver and everything's good.
Nice. Right on. Good stuff.
Okay.
All right, guys. Thank you so much for those of you who are liking and subscribing to our YouTube and Facebook pages. And if you haven't already and you're watching this, please hit those like or subscribe buttons. And anything you guys can do to help us out, throw some comments our way, stars, thumbs ups. We truly appreciate it.
Yeah.
And so with
and
that,
let us know if you want us to talk about anything.
Yeah.
Put in the comments.
Yeah. If you have a comment, there's a perfect thing to comment about. Just say, hey, guys, I would love to learn about this or that and stuff. So it gives us stuff to talk about too.
Yeah.
So, all right, guys, we'll wrap it up with that. So we love you all and God bless you. And we'll see you next time.
Bye.
Bye.